Most of you know Dr. Silliman. For those that don't, Dr. Scott Silliman is our medical director of the stroke program, and he's very nice to come talk with us today. And don't tell him I said this, but he's like the best boss ever.
Yeah, well, good. I guess we can officially say good afternoon. But I think, Vicki had mentioned that somebody in this group is interested in a talk on stem cells. It's kind of a hot topic right now, so maybe I can give you a perspective about stem cells. I want you to leave here just understanding what we mean by the term stem cells and where we're at in terms of understanding how to utilize it in medicine. Now, I wear a second hat other than being the director of the stroke program here. I also direct the multiple sclerosis program here, which is an immune disease, and I'm going to talk a little bit about that because we're a little bit further ahead in understanding how to use stem cells in multiple sclerosis than we are in stroke, but it's a little bit of a different approach, so I'll talk about that as well. So first off, let's just talk about what a stem cell is. Basically, a stem cell is an immature cell that can be transformed into different tissue types. So as an example, all of us were at one time just one cell. When the sperm met the egg, it was one cell, and then it divides into two, and then it goes into four, and then it goes into 8 and 16, 32, etc. But if you look at your eye, right? Look at your eye. Your eye has many different structures, right? It has the white called the sclera. It has the colored part called the iris. It has the clear covering over the iris called the sclera. And then when you go to the eye doctor at my office, we look at the back of your eye called the retina with an ophthalmoscope. And when each of us was maybe 16 cells, one of those cells was destined to become all the tissue in the eye. So that's a stem cell. So how does it become, the retina is very different at the back of our eye than the white of our eye, and it's very different than the iris. So these stem cells have the ability to channel into different tissue subtypes. And there's 3 main types of stem cells in our body, just 3 main categories. One, and this is a tongue twister, called the hematopoietic stem cells. Hematopoietic stem cells are those that are destined to become the cells that are in our bone marrow, and our bone marrow manufactures our red cells that carry oxygen. That's where our blood is red. And it also manufactures white cells, which are the ones that fight infection, and it manufactures platelets, which help clot the blood. So one type is a hematopoietic stem cell. Did you have a question?
Yes. His me, was there a significance with it being when it developing when it was named cells?
Well, each of those cells is destined to become a different structure. So some are going to become part of the eye, some are going to become our bones eventually, some are going to become the bone marrow, some are going to become our brain tissue. So I'm going to talk about that a little bit, right? So the other 15 cells, each of the other 15 cells is destined to go somewhere else.
So each of those cells could be identified by something in the DNA as to where it's destined to be?
That's one of the challenges. Yep. They all have the same DNA, but it's programming the DNA. Something stimulates the DNA, and it goes that way rather than that way.
It's magic.
Yeah, it's kind of magic. Yep. It might be a little bit of fairy dust over here and a little bit of a full moon over there, but that's one of the challenges. So one of the main categories is hematopoietic stem cells. The other one, which is big, is called mesenchymal stem cells. So mesenchyme basically are the cells that are destined to become sort of the organs in our body, be it our bladder, our heart. It's kind of firm tissue, hard tissue, fat tissue, skeletal bone tissue, or muscle tissue. And the third main kind is neural stem cells, and the neural stem cells are those the immature cells that can, depending on where the fairy dust goes, can either become what we call neurons. The neurons are the main batteries, right? Our brain is a big battery, but we have 100 billion neurons in our brain, 100 billion. and they're the ones that produce the electric charges. Each one has a long arm called an axon, which is the wiring off that battery. We also have neurons in our spinal cord, and the stem cells that are neural stem cells also can become what we call oligodendrocytes. That's another big word. Oligodendrocytes are the cells that wrap insulation around the arms coming off the neurons, right? Just like a wire in your home, if it doesn't have the insulation around it, the copper can't carry an electric current. So the neurons need to have an envelope of myelin around them, and that's made by the oligodendrocytes. The neural stem cells also can become what we call astrocytes. That's the green here. Astrocytes are cells that kind of nourish the neurons and nourish the oligodendrocytes. They move chemicals in and out. They also provide some structure to the brain. And the other one is called microglia. Now, microglia are probably more derived from our bone marrow. They're like cells that kind of come in and out, or stay in the brain and look for infections. But neural stem cells can segregate primarily into neurons, astrocytes, or oligodendrocytes. So again, the three main categories of stem cells, if you just want to think about categories, one is hematopoietic, one is neural, and the other is mesenchymal. Let me just take a little detour here and talk about multiple sclerosis. Multiple sclerosis is an autoimmune disease where people's white cells, the myelin that's made by those oligodendrocytes in the brain, spinal cord, and the optic nerve, that's the nerve between the eyeball and brain, is foreign. So it periodically attacks it. It thinks it's a foreign protein. It's a cousin of other autoimmune disorders like rheumatoid arthritis. And rheumatoid arthritis, the immune system thinks the covering of our joints, there's a connective tissue covering of our joints, is foreign, so it attacks it, and the joints get deformed. You've heard of things called lupus, where our immune system thinks the organs in our body are foreign, so it attacks proteins in different organs in our body. The strategy in MS is, very simplistically, let's get some stem cells out from Mrs. Smith's bone marrow, some real immature stem cells, and these stem cells, in MS we think that there's a genetic predisposition to it, but there's also something in the environment that's changed the DNA after the stem cell becomes a white cell, so that these white cells misrecognize the oligodendrocytes as being foreign. So the theory here is, let's get these stem cells with the undamaged DNA, and let's get rid of the bone marrow, give high doses of chemotherapy, and then reinfuse the stem cells, and then they multiply, and the immune system reconstitutes itself a little bit differently so that it's not programmed to attack the brain and spinal cord. Now, there's been several study groups in Europe and here in the United States. Most of the work here in the United States is being done at places like Northwestern, I think University of Colorado. It requires an incredible team. People stay in the hospital for several months. There's this period of time, obviously, where they have no immune system, so they're at risk for infections. And the studies have shown that after about I think they're out to 4 years of doing that, probably about 2/3 of patients have not had another attack. So, potentially a long-term remission or a cure. Now, when we do that strategy, it's potentially dangerous. As I mentioned, those patients are predisposed to infection. The chemo drugs, can affect the heart muscle and cause weakness of the heart. People can become immobile after. You feel sick, you're going to get nauseous, walk around as much, so you can get blood clots in your legs, and they can break apart and go up into the lungs and cause pulmonary embolism. This is the same strategy that's being used to treat, you see in the paper, kids with leukemia at the Children's Hospital here who need bone marrow transplants. It's the same sort of strategy as that. Now, I've had personally 2 patients go to Northwestern to have this done because they were not responding to the normal drugs that we use to treat multiple sclerosis. Both were younger women, I think in their early 30s. One woman is now 2 years out, has had no attacks. My other patient, however, developed a new attack in her brain about 8 months. after the hematopoietic stem cell transplant. So it requires a brave patient to do this, but it's not fail-proof. So that's hematopoietic stem cell transplants. There is something called mesenchymal stem cell transplants. What's mesenchymal stem cell transplants? Well, we do know that if we take, all of us have a little bit of fat on our body, right? Yeah, even the elite athletes have, 2 or 3% of fat on their body. And obviously fat can grow, right? So we have stem cells in our fat, and they're programmed to become fatty tissue. But what's interesting is we've learned that, and fat is a type of mesenchymal stem cell, right? It's part of the structure of our body. But we've learned through science that if you program a fat cell correctly, it can actually transform into other tissue. There are ways to use fat cells, through in a petri dish. You can actually apply various chemicals to it and signaling compounds, and it can become a neuron, a brain cell, through manipulation. Yep. I don't know the pathway.
But you're taking cells out of
fat.
one place, and then how do you get it?
I'm not saying,
right
yep,
place?
well, that's what I'm getting to. In a petri dish.
Okay.
All right, in a petri dish. So you can change that cell that would normally become a fat cell, and you can make it into a neuron. So the strategy here is called mesenchymal stem cell transplant. Is taking the fat cells, maybe just through a needle, getting some fat out of the side of my belly or my buttock, and spinning it. The stem cells you can separate from normal fat cells through various techniques, and then injecting those stem cells into my blood, and the theory being that those stem cells are going to spread throughout the body. If they get in the brain, hopefully the milieu will be there where they could transform into neurons or oligodendrocytes. There's a lot of iffy. Doing something in a petri dish is very different than doing it in the body, all right? Now, there's been some small studies in stroke, but they're just primarily safety studies right now, okay? There is a study also at University of Miami in Alzheimer's disease. And Alzheimer's disease, they lose these neurons in the memory centers much more rapidly than that associated with normal aging. So they're infusing mesenchymal stem cells from young adults who obviously don't have Alzheimer's through an IV into patients with Alzheimer's, just to determine if it's safe. But down the road that may become a strategy for Alzheimer's disease. Now you will see, I want to emphasize this strategy is unproven. However, my word of caution to everybody here, that you will see advertisements for centers that will do this. Obviously, when you get there, there's probably 4 or 5 pages of waivers to sign drawn up by their attorneys that probably guarantees this. We cannot guarantee that this will work for you. I promise you your insurance won't cover it. So people are paying cash out of pocket to have this done, all right?
Or, like you said, the studies at a couple of schools?
Yeah, I mean, if as part of a research trial, that's different, right? Part of a research trial is different. That's not being done, that's usually non-gratis, free. You're helping mankind, all right? Yep.
From what I understand, what's out there, what people believe is that those stem cells, once injected into your body, will transport themselves to whatever areas of your body that needs.
That's right, and then transform.
Right.
But it's unproven.
Right.
Right, but you're right. That's exactly it, simplistically. So you can go online and see this. There is something called stem cell tourism. I found this off the internet. Dr. Wu in China will take your $30,000, put you up in a posh hotel in Peking, across the street from a nice amusement park. He is using this. He claims he has over 30,000 patients or something he's treated. But he's advertising for, and these are the most desperate parents with children, with cerebral palsy.
Absolutely.
Cerebral palsy is typically damage in the brain. It could be a stroke while a child's in the uterus. So he's advertising it for cerebral palsy, Parkinson's, stroke, multiple sclerosis, traumatic brain injury, people that have been in car accidents. And obviously in China things are less well regulated than they are here. And of course, you know, he's going to show success stories, but some of these success stories may relate to the fact that these patients, after they're infused, they get vigorous physical therapy, you know, like 4 and 5 and 6 hours, you know, a day. And these are actually patients who may be deconditioned, and it's the physical therapy component. Dr. Wu has not published any of his studies in a reputable medical journal, so I would think if he had the answer, he would be the Nobel Prize winner, it'd be published in the New England Journal of Medicine, and we'd be having him here for grand rounds, you know, so, but be very careful about these things. This is an interesting article if you want. This is also another example of the dangers of stem cell tourism. This was an article, actually you can go online and just do stem cell tourism, New York Times. It was published in the New York Times just about 3 years ago, one patient's experience, and it was subsequently published in the New England Journal of Medicine. So Mr. Gass was a patient with a fair amount of money who had a stroke, and he traveled the world to get stem cells. He went to Mexico, China, and Argentina, and apparently he had infusions of mesenchymal cells, but he also had infusions of what we call fetal cells, you know, cells from fetuses infused. And it included not only the blood, but he actually, at one center, they infused cells through a lumbar puncture into the spinal fluid. And Vicki said that she was going to put numbers in a hat. We're going to do an example of a lumbar puncture on one of you today. No? Okay.
That's Mark Rock.
Yeah. So they actually, in the spinal fluid, infused some of those cells thinking that they would get to the brain and take care, you know, repopulate the area where he had the stroke. But guess what?
What happened?
He developed, he came back to New York City, developed progressive low back pain, both legs became paralyzed, he couldn't urinate, and his MRI, you see this, all this white in here? He developed a tumor, and they opened it, and there's this tumor here compressing his spinal cord, and the tumor showed no features of cancer, but it showed highly proliferative cells that were difficult to describe. They represented immature brain tissue. So probably what happened is these stem cells that were injected into the spinal fluid proliferated. They multiplied as immature brain cells, caused a tumor, and it compressed his spinal cord. So this is a cautionary tale about trying to do too much.
So did they just remove them?
They removed the tumor, right. But I don't think he recovered. And if you look there, his total cost was $300,000 to do this. Yep.
Would they call that a teratoma?
It's kind of, yeah, teratoma is more mesenchymal cells.
Okay.
But yeah, these were just immature, undifferentiated glial cells. So, you know, glial cells can become neurons, or they can become oligodendrocytes. So it was before that dividing line. So
Basically, he had somebody else's brain growing in his spinal cord?
yeah, somebody else's, or a combination of multiple people's cells causing a tumor. Yeah, they were happy there, being fed, you know, with the spinal fluid, decided to take up residence there, multiply, and have children.
So in other words, the body was actually rejecting those cells to a point?
No, the cells were happy there. The body wasn't rejecting them. The cells multiplied. They grew.
Okay. So
You know, they went from maybe they injected 10,000. It became 30 million of them, causing a tumor.
But they weren't doing it.
They weren't doing anything good.
Right.
It just was like a mass of cells there.
I think it's a success story, and as soon as I mention the name, you're gonna know who I'm talking about. Bart Starr.
Okay.
And didn't they experiment with stem cells and we're still alive?
Yeah, I'd have to look at that in more detail. It's a good point. I'll have to look at that.
I think,
and get
what,
back to
didn't he
Vicky.
suffer a stroke and a heart attack or several things?
Well, I know they've been looking at stem cells to replace heart tissue after heart attacks.
So you know the name, but you're not familiar with
Yeah,
it.
I'd have to. I remember this story, but I can tell you that he didn't regenerate any brain tissue. I'll have to look at it again. Yeah, I'll look at it again.
Because I'm a big fan of the Green Bay Packers.
Oh, yeah, great team.
That's why I knew so much about it, and as I said,
Yep.
he's still.
I can look it up.
He did not pass away yet, so he's still alive, and I think he's in a wheelchair, but he did go back to Green Bay a couple times.
Okay. Yeah, he had 2 strokes and a heart attack. I'll have to read up on it a little bit more.
But,
Oh, he went to Tijuana, Mexico for stem cell treatment, experimental stem cells. Yeah, I'll have to read up more on it.
so you're not sure if it was a success or not, other than the fact that he is still alive, right?
Yeah, he's still alive.
Still alive.
But remember, the stem cells are being used to try to improve repair damage in the brain and such. So, not necessarily to maintain life. So let's just talk a little bit about stroke, where we are with stem cells. So I'm going to just show you a few examples of some studies that were published within the last 2 years. This is an example of the studies that are being done right now. So we tend to divide studies into, you've heard the terms phase 1, phase 2, phase 3. Phase 1 is typically an exploratory study that just tries to determine the right dose of a drug or the right technique in terms of administering a drug. A phase 2 study is primarily focused on safety. After the technique is worked out, is this safe? But you do gather some information concerning effectiveness. Phase 3 is the final stage where we evaluate the effectiveness of a drug. And once we've determined it's safe in a phase 2 study. But basically this is a phase 1 study. So phase 1 implies, and it was open label, that implies all the patients knew they were going to be getting this procedure done. There was no sham procedure. And it was an attempt to evaluate the technique to do this. And there were 13 men. I'm not quite sure why they only selected men. All were above the age of 60. And they were all about, on average, about 2.5 years out from their stroke. The mean, what we call NIH stroke score, is 7. A normal stroke score is 0. The highest it can go is 42, and it's a measure of a degree of deficit. An NIH of 7 would mean that there's some moderate residual physical deficits from the stroke. So for example, I could get a 7 if I had trouble seeing over here, significant weakness in an arm, and maybe my face was droopy. That would be about a 7. So they obtained neural stem cells from, human fetal cortical, from brains of fetuses that obviously were not viable. And the cells were injected by a neurosurgeon into the brain, and I'll show you where they did it. So here's an MRI of a patient that had a stroke. When we look at MRI, it's like you're looking from below. So this is the left side of the brain, and this is the right side of the brain, and this white here is an area where there's been damage to the tissue. And this is in an area right here where the neurons are that control motor function. So this patient would have weakness primarily in the right face and arm. It's an area that does play a role in speech production, so this patient probably would have significantly slurred speech. I picked this because I suspect this is a patient that would have an NIH of around 7. And they injected the cells into the putamen. The putamen is an area here. It plays a role in programming movement. In patients with Parkinson's disease, the putamen doesn't work correctly, so they get tremors, they move slow, they have walking dysfunction. What this study showed is that patients, again, this study was done just to determine if this technique was feasible. Obviously, if 5 out of the 7 patients developed fatal bleeding in the brain, it's not effective, or if they all develop infections in their brain, it's not effective. But they did find that it was safe in these patients. I don't think there were any. I think one patient had a very minor hemorrhage, but no other major side effects. And they just did an exploratory efficacy endpoint. Most patients improved across several minor indices of function. You know, maybe their walking speed improved a little bit. But this is sort of where we are right now, is trying to figure out how and where to inject. Some people advocate that maybe we need to inject the cells instead of into the brain tissue itself. We should inject the stem cells. You see these black areas here?
Yeah.
Those are called the ventricles. They're fluid-filled sacs. That's where we make our spinal fluid, right? The spinal fluid is going to bathe the entire brain. The question is, if you inject stem cells here, how are they going to know to get out here? But if you inject the cells in here, the fluid is going to circulate throughout the brain. This is in touch with the surface of the brain. You can see that there's some spinal fluid on this side. Perhaps the stem cells are going to be more apt to getting into the damaged region if we inject it into the ventricles there. Now, as I mentioned before, other people are also advocating that maybe we inject it into the same spinal fluid bathing the brain is floating down here. And it's obviously less invasive for me, you know, to do it in the office with a lumbar puncture than it is to put a needle through the skull. To get to that area, you do have to go through brain tissue. So there's always the risk when you put a needle through the brain tissue to get here of having bleeding, which there's also a risk of seizures later in life. There's also a risk of infection occurring. So other people are advocating maybe we should just be using the spinal fluid access in the lower back.
Why not the carotid artery?
Well, the carotid artery, that's another way potentially to do it, is to do a catheter-based. Other people are advocating, you're right, maybe we should do an angiogram, put a catheter up through the carotid artery and inject the cells through that route. The only problem with that is that the cells have mass, so they can go out and they may occlude other arteries and make the stroke bigger or cause issues in other areas. Or what happens, other people worry that what if the cells get stuck? You know, our arteries are lined by Teflon coating, and what if the cells get stuck to that? Then they can grow and you get that tumor in your blood vessel and it occludes it off, or it can rupture the artery. So yes.
So what they result, they just inject the stem cell and hope that they go to the right place.
That's right. Now they hope. Yeah. So the question becomes, how do the cells know to get there? It's kind of interesting. You know, our brain, our entire body. I mean, if you think about it, when I cut, you know, if you cut yourself here, you burn yourself. It's interesting. All the inflammatory cells know to get there, right? You get swelling.
Yeah.
So there are signaling pathways throughout our body that cells can communicate with each other. And you do get inflammation in your brain. Around a stroke, the immune system does migrate to that area. So there are ways that those cells communicate with the body to say, hey, something's not right here. Now that does raise the question about the timing of this. Is it better to do it within a week after the stroke, because maybe those signaling pathways are more active? In this study, again, you know, this was primarily a safety study, so they wanted to have healthy patients that were, you know, they didn't want patients having heart attacks or kidney failure from this, so these were all healthy males at 29 months. And maybe at 29 months, those signaling pathways aren't that active. So the best time may be when we have our patient over here on 4 North, you know, to do it. So that's another big question, is the timing of it that we need to work out. So, yeah, we talked about the route of administration. We just talked about that. There's a low graft persistence of transplanted cells. A lot of the transplanted cells don't live. And so the other question is, how many do we need to inject? Do we need to inject 100,000, 10 million, 100 million? So that's another question that we need to answer. And also, like any therapy, we need to also identify which patients are most likely to respond. One of the issues that we deal with in stroke is that some of our stroke patients, maybe it's the patient who's 80 that's had an 80-year-old patient, for example, who's had years and years of untreated high blood pressure. There's hundreds of thousands of little microvessels in the brain, and those microvessels are damaged even though they haven't caused a stroke. And if we do a stem cell transplant on that patient, are those stem cells going to be adequately nourished? You know, they need sugar, they need oxygen, they need nutrients. In patients with stroke, one of the challenges, what if they have an occluded carotid artery here, and we know blood flow is going to be less to that hemisphere? Are those stem cells going to be adequately nourished? So selecting patients is going to be key also. Could patients on aspirin, could aspirin, which is a blood thinner, and it obviously blocks a certain pathway, could patients taking aspirin rather than Plavix, could they do worse because it may interrupt signaling within these stem cells? So there's a lot of unanswered questions. This is an example of where we are right now with stem cells. I think most people think that the mesenchymal approach probably is not going to work for, when we infuse through here. It's probably not going to work. You're not going to get enough cells into the brain through that route to really change, to populate the stroke area and have those cells differentiate into neurons or oligodendrocytes. Most people think that this is an example, probably this is the approach that will ultimately work, but I think as you can see, we're still very early trying to figure out how, when, the right patients
And
to do this.
there also appears to be an issue with deriving the stem cells from the human fetal.
There's ethical issues with that also. Yep, there's obviously
Because I
ethical
know you
issues.
said earlier, get it from your fat, so
Yep.
fat on your body, but to go to the
Right, yeah, the question would be too, can you eventually, you're right, can you get, there's ethical issues with
Right.
this. Your question's very good. Could one approach be that we get our own adipose tissue and put it in the petri dish, begin the transformation process, and then inject them? So that may be another approach. So that may be another way of doing things. So this is kind of where we are at right now. The other approach, we have what are called neuroprotective drugs. We're involved in a study. We don't have, when I use the term neuroprotective, if we look at this stroke, what if when this patient came into the emergency room, we gave them the TPA, the clot dissolving drug, so we're able to restore blood flow to this area of the brain. But what if we gave them a drug that helped maybe energize the cells that were kind of stunned and damaged by the stroke that eventually are going to go on to die? What if we could preserve those cells and make this stroke maybe 1/10 this size? So we call that neuroprotective strategy. It protects the nerve cells from damage and makes them stronger, more able to withstand the insult that they've sustained. So that's another area that we're exploring research. So we're involved in a study right now. It's a drug that's derived from celery seed, believe it or not. And what it does is it has several effects. One is it dilates blood vessels in the brain, so it may help promote more oxygen flow and sugar to that area of the brain that's been affected by the stroke. And it may also create a situation within the nerve cell where it utilizes oxygen more efficiently. So hitting it from two sides. So we call that a neuroprotective strategy. I think we're going to find a neuroprotective strategy well before we figure out the right way for stem cell transplants in stroke. Now, on the other hand, I talked about MS. I think MS, because it's hematopoietic stem cell transplant, where there's been so much research on hematopoietic stem cells in the cancer world with leukemia and lymphoma that we're far ahead in reorganizing the immune system and treating diseases potentially with hematopoietic stem cell therapies than we are with neural stem cell therapy. So I think I'll stop there. A lot of long words. But I want to lay a foundation here for you. Okay? Yep.
Thank you.
Thank you.
All right.
You guys ready for the test?
No, while I have you here, I can just give you another research update. Actually, I just forwarded. We had an article come out yesterday. About 15% of all strokes in the United States are due to rupture of blood vessels in the brain. We call that hemorrhagic stroke, intracerebral hemorrhage. And right now, there's no therapy that we can, there's no TPA for intracerebral hemorrhage, right? There's no drug we can give people that reduces the size of the hemorrhage. What we know from animal models of stroke, when people have a hemorrhage, right, our blood is red. Why is our blood red? It's because our red cells have iron.
Yeah.
Iron in them. Yep, iron.
Yeah.
So those red cells break in the brain, and the iron leaches out of the red cells. Here in Florida, a lot of people have well water. They use well water to irrigate their lawns, right? What does it do to the sidewalk? It stains it, right? So iron binds. It's very strong. It's charged. It binds to other material. And if it binds to those neurons and oligodendrocytes, it can damage them. It oxidizes them. So the theory here was that if we give a patient with an intracerebral hemorrhage a drug that chelates iron, it sucks it out of the brain. There are drugs. There are people that have hemochromatosis, where genetically they manufacture too much iron, and the iron gets deposited in our organs and damages them. They're given a drug that removes it from the body. What if we gave these patients with an intracerebral hemorrhage a 72-hour infusion of this drug? So we were part of an NIH study. Each of you contributed a little bit of your taxpayer money to it. The study, unfortunately, did not show any benefit, but it was an interesting theory. So we're still trying to find a medical therapy for intracerebral hemorrhage after patients come. In one sense, it's kind of a neuroprotective strategy. It was a valiant effort, but unfortunately, it was a negative trial. So.
How about aspirin? Was there new news this week?
Oh, okay, that's a good point. Yeah, good question. I'm getting a lot of questions about that. So, when I was in medical school and Vicki was in nursing school, just a short time ago, right, Vicki?
Dinosaurs around the earth.
Yeah. You all heard the saying, an aspirin a day keeps the doctor away, kind of like right? Take an aspirin. You're over 40, take an aspirin a day. It prevents heart attack, it prevents stroke. Well, we've learned in the last month or two that that's not the right strategy. If you're using the aspirin to prevent your first heart attack or your first stroke, even if you're diabetic, people with diabetes have a higher risk of stroke and heart attack. The reason being that aspirin can be associated with bleeding that can be significant, right? People on aspirin can develop ulcers in their stomach that can bleed. People on aspirin, if they fall and hit their head, they can get bleeding between the skull and brain that can compress the brain.
Even the low dose 81 milligrams?
Yep, even the 81. So there's been a rethinking of whether or not that strategy of an aspirin a day is good. It does prevent some stroke and heart attack, but the risk of major bleeding, hospitalization, requiring multiple transfusions, and potentially dying from bleeding, that risk outweighs any benefit. Now, that's different than to most people here who are taking an aspirin a day, because after you've had a stroke, or after you've had a heart attack, or after you've had stents put in your heart, it's better to take an aspirin a day than not, because your risk of a second stroke off aspirin is much higher than the general public if you don't take aspirin a day. So
aspirin every other day.
Yeah, aspirin every other day may not. There are some people who do that. To keep the blood thin, you do probably have to take it every day. Probably do. But that'll be other stuff. Maybe from a primary prevention viewpoint, though, down the road, that may have to be done.
Dr. Silliman,
Yep.
you said after a stroke, you would probably be advised to take aspirin?
Aspirin or an aspirin-like drug. The other one out there is called Plavix or clopidogrel. Mm-hmm.
Well, in my case, I thought I'd heard that, so I asked. And you or my general practitioner said that I didn't need aspirin.
Every case is different.
Yeah.
Every case is different. There may be some other issues that confound that, but I guess I just don't want people to panic if they're on an aspirin a day right now to prevent a second stroke, okay? So, but it was interesting. Yeah. All right. Well, thank you.
No big cure for MS this year.
No big cure, but we've got, many patients that we have with it, that we diagnose now, we can keep it quiet. So, yeah, MS management, the field has changed quite a bit in the last 20 years.